talk a little bit about heart disease and stroke in Asians. And so I just wanted to point out to you that what happened was when we were setting up the lecture series, Diana chose the title for me, and I said, well, we can't be quite all that emphatic, so I added a little question mark at the end so we can show you the data and you can make a decision as to whether it is truly on the rise or is there just a question that we need to delve into a little more about what the status of this disease state is. And so as Don was mentioning, I'm actually a third generation San Franciscan. And so when I came into practice, my father had graduated from UCSF. My older sister had graduated from UCSF in the School of Pharmacy. Then my next older sister graduated from the School of Medicine. My brother was in the School of Medicine. At the time, I said, and then it was up to me to decide where I wanted to go. And I said, do I have a choice? So I was the third one in line. But then when I came out, it was actually a decision deciding as to what would I do and would I be busy enough? Because at that time in Chinatown, because of healthcare insurance and the poverty socioeconomic status situation, we actually had recommendations for new young doctors coming out. And it was always, you need 1 foot in Chinatown and 1 foot out. So that you can actually have enough patient mix so you can make a living. So I wanted to basically be very busy, and I wanted to take care of patients. So I chose cardiology, and indeed it is the most common cause of death in the Chinese population, and I'll show you some data to support that. So we have to give these slides to say that we do not have any financial disclosures. The only conflict is that I am Asian, so I will be giving a talk about this topic. So the most recent statistics that are available from the American Heart Association are the heart and stroke statistics update in 2020, the trends in cardiovascular disease in the United States, and then in cardiovascular disease and selective state by ethnicity, and then cardiovascular disease in general in the Asian population and stroke. So these are the particular topics that we're going to talk about, hopefully. Okay, so the first slide I wanted to show you was data from 2017 from this Centers for Disease Control and the National Health Statistics Center. And this is basically males and females and the leading cause of death. Now, this is a little bit a slide that actually requires a lot of unpacking, because although you can see here that heart disease is listed as number 1 for men, cancer is number 2 for men, then 3, 4, 5 is stroke, and then down here 6 is diabetes, and then 7, 8, 9 is influenza. Now, if we just said we're only interested in heart disease, then we would look here. But what have we learned is that people who have cancer actually take medicines that can adversely affect the heart. It has gotten to be such a problem that within cardiology, we have actually developed an entirely new subspecialty that deals with cancer patients and because of their effects on the heart. How many people have heard of the new immunomodulators, where they make medications that allow the body to target the specific cancer? Well, one of the things that we've learned about those is that those immunomodulators can actually attack normal muscle. And so the heart is a muscle. So we've had patients who've had bad pericarditis, myocarditis, and they come in florid heart failure and very dramatic. There are medicines for cancer that basically destroy the heart muscle. So we have to limit those. You see them very commonly used in patients with leukemia or breast cancer. And so they have to very carefully watch the dose. They have to watch the heart muscle very carefully. So cancer is, even though it's number 2, is something that we also consider a major source of heart disease. Now, we have stroke all the way out here for men, but in fact, with the American Heart Association saying that 90% of stroke has the exact same cause as we see for heart disease. So it's what's called ischemic strokes. That's basically where the arteries develop plaques inside, and at any time they can rupture. How we treat it is exactly the same. You know, you've heard of the clotbuster medicines. Of you can get into the hospital within a certain number of hours, and they can take a look at you and treat you at a center. They can actually reverse all of the neurologic deficits of a stroke. So I will talk a little bit about the different kinds of stroke later on, because this is the most common currently in the United States. Not so much for the Asian population, okay? And then diabetes here. Although it's listed and everyone has heard about diabetes, one of the things that is least talked about is that in the 80s and 90s, there were a series of research articles, mainly from the Danish cohort. And what they found was that if you take a bunch of diabetic patients and you take a group of patients with heart disease, and you monitored them for the next 4 years, they had the same risk of having a death from any cause, okay? And so for a long time, that was given the label to diabetes as a cardiovascular disease equivalent. So that your risk of having a cardiac event was just as high if you had diabetes without heart disease or heart disease, which already carries with it its own risks. So in fact, if we were to look at this and say heart disease is number 1, then we say, well, with cancer, stroke, and diabetes. Now, is there any other thing within the top 10 that is also a major problem with heart disease? Okay, so usually Alzheimer's disease, not a whole lot we can do about that. With suicides, and not much there. Chronic liver disease and cirrhosis, not much there. But influenza is actually another cause of hospitalizations, and most of the time they come in with an exacerbation of their heart disease. So about 10 years ago, the American Heart Association basically said, if you are over age 65, that you should get a flu vaccine every year to prevent a heart exacerbation. Okay, so this was considered to be one of the most preventative things that you can do to prevent a heart problem. Even if you didn't have it, or you have something that is well controlled, like high blood pressure or something like that. So that's the thing there. Now, women are actually in the same boat, although they're not quite as commonly in terms of percentage for the first thing. But what you see here is that the second cause, again, is cancer. Interestingly enough, for men, the third cause of death is unintentional injury, so we may be a little clumsy. But then it's lung disease for women. But then the fourth category is actually stroke. Okay, and then going down the line, diabetes is here and influenza is over here. So heart disease actually makes up several categories of the top 10 leading causes of death. And so I wanted to make sure that everyone is aware that it's not just heart disease alone. Now, when we look at the statistics from the vantage point of the American Heart Association that puts a lot of these statistics together, they usually add heart disease and stroke. And so instead of cancer as secondary, they'll put these two together. So we will always, at least to this point, be considered a situation where it's number one leading cause of death. All right. Now, the next slide is actually leading causes of death by age group. And so when does heart disease actually start? And so within the top 10 causes of death in the youngest age group that we usually look at, you could see that heart disease is number 4. So even at that age group, we see heart disease as a major one, and diabetes and stroke. Okay, so that combination of diseases tend to go hand in hand. And so you see that no age less or beginning at 25 is heart disease not considered one of the leading causes of death. And so when we move up to age 45 to 64, that actually happens to be an age where cancer is coming along and is very common in diseases. But you see that heart disease then jumps up to position number 2, and diabetes and stroke come back here. And what you see here is that influenza and pneumonia are actually not part of the top 10. Okay? So now, what is significant about this age over 65? Because when statistics were started to be gathered and up to the 1940s and the 1950s, average lifespan was only 65. So a lot of this stuff didn't even exist before 1940, 1950. So this is a whole new category of people that we're starting to look at more carefully. And as you may have heard, the American and the national and the international population are getting so that we have the fastest growing demographic in the world is the group over 85. Okay, so when we look at that, heart disease is number 1, as I mentioned, cancer, stroke diabetes, and then influenza as another particular problem. Finally, let's take the oldest group, and then you can see here that heart disease actually increases. I'll show you a little bit of information why that's the case. But then, and then stroke still remains quite common, and influenza. Now, I didn't mention exactly what the percentage of people with diabetes that actually die of heart disease, but it's about 80%. Okay, so the diabetes complications are not the usual cause of death for people with diabetes. And so we do consider it an equivalent to having heart disease because that is the usual modality. Okay? All right, so let's take a look at this next slide because it's an actually very interesting slide that shows that heart disease was on the rise beginning in 1950, and it didn't seem to have an ending. It just seemed to be going straight up without any changes. Then at about 1970, you see this little dip, and it tended to kind of waver around at this point. Does anyone know what happened in 1970 that might have caused this? Okay, so think back about that time, and that was when the U.S. Surgeon General was starting to say smoking is bad for you, right? They started to say high blood pressure is not good for you, and so you should treat it. And so there was an initial rally, so we should take care of this stuff, and you saw an immediate drop in the mortality for heart disease. And then it kind of went, and then what happened here? Then it started to take a big drop. So what happened in 1990? Does anyone remember? Okay, huh? The food pyramid, yeah. So we'll talk a little bit about the food pyramid, but no, that wasn't it. Okay, close. That was when they actually developed cholesterol-lowering medications. You've heard statins. So we had a big project to actually teach physicians and patients and everything about what is the ideal cholesterol, right? And then we said there's a medication now that has very low side effects and is very effective in lowering cholesterol, and wow, everything just started to drop. Okay? Now, if we look back at this curve for heart disease, okay, and we go all the way back to 1900, there was only 1 year where it was not the leading cause of death. Does anyone know what that year is and why? 1918, excellent. And the reason was? Yes, it was the flu. Okay, so, you know, we were worried about, we're not worried about it. It was actually a very bad thing. The flu overtook the United States population as the leading cause of death for that 1 year. And then once they started to get that taken care of, then it became heart disease again. So you could see here that cancer as the number 2 cause of death, especially in the middle-aged and average population, is first and second cause. You could see that that's on the rise, and it doesn't show any signs of slowing down. Here's the one thing that is worrying every single public health person who's involved with heart disease. You see here that it seems to be coming down great. People are cutting their smoking, they're eating, they're taking their medicines, they're watching their cholesterol, they're doing all the right things. But all of a sudden in 2010, it stops going down. Not only that, it's starting to rise. Okay? So this little rise for this 3 years is enough to make all the public health officials worry that we are losing ground on managing heart disease, and as well as that, stroke and diabetes. Okay, so let's look a little bit more at some of the data from different sources. And if we look at the age 45 to 64, we see in that particular patient group, and we look over the last 18 years from 1999 to 2017, that cancer is dropping, heart disease is dropping, but again, in 2010, there just seems to be a leveling off of that decline. Okay, so where is that leveling off coming from? Okay, we still have the same medicine. We have even better statins now than we did before. We have better treatments for heart disease. So why is it tapering off? Okay, now we separate that into men and women. We could see for men, the cancer rates are death rates are actually dropping. Men, again, coming down, and then around 2010, it takes a corner and it just flattens out. It's even starting to go up a little bit higher. Women also coming down, going up after flattening out, but not quite as dramatically as in men. Now, so let's look at the reason why you all came here, well, how does this affect Asian Pacific Islanders? And we could see that if we look at the population by ethnicity, and we break it up into the 4 major ethnic groups that they usually put on the census, but now they're getting a little bit better about breaking it down into even more discrete populations. You could see that the white non-Hispanic population was what we considered to be the standard, not so much because they had a classic amount of disease, but because they were just the majority population in most centers. Right. I mean, the United States, California is one of the very few states where the white population is not majority anymore. Right. They're only 49%. So so this would not be quite the same, but the ratio of disease in that setting is pretty much similar in these things. So here's the non-Hispanic white population that we consider to be the standard mortality from the disease because of the majority. And then you can see that the non-Hispanic Black population actually has a significantly higher incidence of cardiac disease. The Hispanic population is slightly less. And look at the Asian Pacific Islanders. They're actually quite low. Now, everybody's known somebody who's had a heart attack or heart problems and stroke. And so you wonder whether that is real or just happened to be the place or this timing that we saw a decrease without any splaying out. So we'll try to look at that even a little more carefully. So where did this change come from for cancer and heart disease? And so if we look back at some of the statistics on the statewide basis, we can see that cancer was rising, and then it actually crossed heart disease as a leading cause of death in the Hispanic population. Now, what else do you notice about this? This actually occurred well before we saw that change. It occurred in 2008. Okay, so this is actually a fairly significant finding. Now, when we look at this curve for the heart disease for the Hispanic population, it doesn't drop. It stays the same, and then cancer just went up. Okay, so in fact, heart disease may not be decreasing. It may actually be the same, and cancer is just getting more common. Now, what was eye-opening to me was that same change over here occurred in the Asian population 8 years before that. Okay, so in 2000, heart disease in selected states was actually even with cancer, and then it became the second leading cause of death in those particular states. So I always like to say Asians lead the way. This is not the way we want to go. Okay, so, but then we see that for heart disease, again, there was no decrease, okay? It stayed the same. It's just that in the total volume of people, and even though Asians are considered among the fastest growing minority population, it still is 4 to 5% of the national population. So numbers are usually hard to get by. So if we look at all the states in California, and in the United States, so I'm so California centric, right? You could tell, right? The only thing between us and Washington, D.C. is nothing. So there are only 2 states where cancer was the leading cause of death in both 2000 and 2014, and that was in Minnesota and Alaska. Okay? Now, in those states, pretty much similar to what I had showed you in the previous slide, where cancer is now the leading cause of death, in 2014, but in 2000, heart disease was, you could see those are all the blue states. Not politically blue, just happened to be blue. Okay, so we have these states, pretty much coastal states, except until we get out to Colorado, Kansas, and Nebraska, where we see that cancer is actually overtaking heart disease. And then those states where heart disease was the leading cause of death in both 2000 and 2014 were all these green states. So they're either changing closely but didn't quite make it. And so I'll show you some of that data as well. So I just picked a state at random to show you for Asian Pacific Islanders. New Mexico was one of those states where cancer is now considered the leading cause of death. But then heart disease now is just right next to stroke. And then right behind that is diabetes. And again, we have that influenza, which all contribute to heart disease. And not to say that cancer treatment doesn't lead to heart disease, but that is certainly there. But if the first diagnosis is cancer, then that's how we usually do it from a statistic standpoint. Okay, and you could see that in the usually majority population now still, at least in New Mexico, heart disease remained number one. And then in the Hispanic population and the Asian Pacific Islanders, it had already switched over. All right, so if we look nationally and we say, well, what percentage of this population actually has heart disease compared to the total population? And so we just take the non-Hispanic whites. It's about 11.5%. Asians routinely come out at the lowest end, okay? But they said it was stable. They said this was also decreasing, but I showed you data that it's really not. It's actually going up. Okay, so that's why I actually put the question mark. We have actual numbers to go with that trend going up, and so we still have to make a decision. And the federal government makes a decision by doing what? They put more money into the research to take care of it. They put more money into the healthcare system to take care of it. The Heart Association, American College of Cardiology develops programs to take care of these things as well. So I wanted to just kind of give you the latest statistics that I could find in terms of national statistics. And so nationally, we have heart disease as the leading cause of death, but very close. It's a 23 to 21% with malignant neoplasms, and then cerebrovascular disease at number 5. But if we look at specifically the Asian and Pacific Islander population, that is reversed. So cancer is number 1. So here you see it as number 2. That's it's now in first position. And then those two are reversed. And then influenza is actually a fairly significant leading cause of death. We don't know exactly what the reason of that. If we look at San Francisco, we have very tightly populated populations that live very tight together. So that may be a cause for having more influenza. The closer you are and the more in contact you are with other people, you can spread it a whole lot easier. Again, cerebrovascular disease is here, and one of the things is that diabetes remains over here. Now, one thing I just wanted to mention, because it caught my eye, was this is 2017. And if you look at here, the first 9 causes of death, And we know that from the slides that I showed you earlier, Asians and Hispanics seem to lead the way in terms of things that are happening. What do you see here that is new, that is not in any of these other causes of death? This cause at number 9 and this at number 8 was actually intentional self-harm suicide. So probably needing to, in the next couple of lectures, we're going to have Dr. Lee talk about mental illness in the Asian population, and this may be a very important topic, especially for our population to deal with, because it's already starting to show up as a leading cause of death within the top 10 causes. Okay. So, one more look at the major causes of death in males and females of the Asian Pacific Islander. And you can see heart disease and stroke here. Again, accidental or unintentional deaths from injury. Here for men, diabetes is very prominent here. And then similarly splayed out for women. Okay, now, this is a very busy slide, but I want to walk it through you because this is one of the areas of research that the people involved with studying the Asian subpopulations are very keyed on. Now, so we have a couple of researchers, especially here at UCSF. Have you ever heard the name Dr. Alka Kanaya? She is a very highly respected researcher, a clinician researcher who studies the Asian population, but primarily the South Asian population. Okay, and then the other person down at Stanford is Dr. Latha Palanapian, and they've written several articles on the Asian populations. And then what they consider this, these 6 subpopulations, Asian Indians, Chinese, Filipino, Japanese, Korean, and Vietnamese, account for 85% of the Asian population in any state or in the United States. And so they're trying to get data from these things, and there's only select centers that actually collect enough data to break it down into this group. And so it's taught us a lot. So anytime we ask for Asian populations, you could tell. If you're Chinese, you're not Asian Indian, right? So hardly anyone identifies himself as an Asian unless that's the only box that you can check off on the census, right? And that's not the case anymore. So what we see, and we'll just focus here on all-cause mortality, diseases of the heart, and cerebrovascular diseases or stroke. This is the white population for comparison, and this is the aggregate Asian population. So if we took 100% of Asians, then it would come out to this line. So all-cause mortality, you can see from 2003 to 2011, it's pretty flat. If anything, it's going down very slightly. You can see that is happening also in the Chinese population. It's happening in the Filipino population, Japanese population, Vietnamese population, the white population. What's happening to the Asian Indians? It's going up. And one of the things that we looked at when we look at age-specific causes is that this group is the only group where between 25 and 44, the leading cause of death in that group and no other is heart disease. Okay? So in all the other populations, we look at accidents, young adults either driving too fast, taking drugs, all the other possibilities. Now, when we look at heart disease, it actually is quite similar. So you see the aggregate Asian population is decreasing. We could see that population decrease in the Chinese, Filipino, Japanese, but it's flat to slightly rising in the Asian Indian population. And the other thing is that it's similar both in males and females, so it's non-discriminatory. All right. In this one, however, you see that the Vietnamese population, as with this one, is flat. Okay, so they're not decreasing. They have a good sizable population here. Malignancies gets a little bit splayed out, but the Asian Indian population I see are particularly concerning because for every single one of these disease states, these three, you see not a decrease or flattening, but a rise. Okay, so when they talk about Asian heart disease and stroke on the rise, then you have to say, which Asians are you talking about? Okay, where did you get your data? So I was part of a major study here looking at the Asian population, and then I found out that their population was the San Francisco VA, which is an excellent place, and they have a lot of Asians. 99% of their Asians are Filipino. So it's not something that we would be able to relate to yet, but for the Filipino population, that was a very important piece of information that we're not just talking about Asians in general, we're talking Filipino Americans. Okay, so that's just something to keep in mind when you start reading about Asians are having this or Asians are having that. Yes, which group of Asians are we specifically talking about? And so we could see for neoplasms, Asian Indians are actually on the rise. It's actually flat to slightly dropping in the Chinese population. Filipino population is actually quite flat here for neoplasms, but in the Vietnamese population, for males, it is actually rising. Okay, and then for strokes, we see that every subpopulation except for Asian Indians is dropping. So even the white population. So that was an important piece of information because when we go into just look at heart disease and stroke, then we see that. This is the 6 major subcategories of Asians, with the yellow line here being the white population, okay? And you can see that when you compare the Asian population, which is splayed out all around the white population, the Asian Indian population is the highest, primarily because they start the youngest. Okay, they're starting at the age group of 25 to 45. Most of these heart disease are beginning at age 45. The blue line or the purple line that's kind of hiding behind the the white is actually Filipino. So when we summarize all this data, we say that Asian Indians and Filipinos are at the highest risk of having cardiovascular disease because they're exceeding what we consider to be the standard. And so the Chinese population is down here. You can see that down here. And Vietnamese and the Korean population is down here. They do come together as people get older, so they only separate out when they're much younger. All right, and so this is women, this is men. So you can see the same kind of distribution for stroke, okay? So the stroke population, again, Asian Indians are at the highest, and as we get older, it seems to be that they have a little bit less, but they start very young as well. And then the Vietnamese, the entire trend is as they get older, just slightly less, but the population as it gets older is actually seeing a lot more. This one is actually quite significant here, is that if you look at the male population and stroke in the male population, the white population has had a pretty steady amount of stroke throughout their lifetime. Okay? The younger Asians actually have a lot more. Okay? And then as we get older, then there's slightly less. Okay? But this is a significant problem because this is a disparity that we, at this point in time, don't know how to explain. Okay? There's either something, we usually like to say in the food first, but there's something going on that are putting Asians at higher risk for having stroke at younger ages and cardiovascular disease for the Asian Indian population. Okay. So I wanted to just bring up this slide. It wasn't the exact slide that I learned this information from, but it certainly will suffice. So if we look at strokes in general, there's basically two types. One is the ischemic stroke, and the other one is the intracranial hemorrhage. That is, so the ischemic stroke I described before, that's where you develop an atherosclerotic plaque inside the artery leading to the brain. And then at some point in time, it may rupture, and then you may have a sudden loss of blood supply to that part of the brain, causing damage to the brain, and that's where you get the inability to move, talk, or get significant numbness. That is also treatable if you can get in time to use one of the what are called thrombolytic agents, so that you can dissolve the clot and actually have complete neurologic recovery with that. And so the other kind is an intracranial hemorrhage. Now, the intracranial hemorrhage by far is the most feared stroke because what it is it's a rupture of the artery. And when it ruptures, the only thing you can do is to go in there and actually surgically tie it off if the patient is stable enough and you can get the blood pressure down, or just bring down the blood pressure and hope that the patient recovers. Okay, so essentially there's nothing interventionally that we can do. And why is that the case? And so why is that important to discuss here is that for ischemic strokes, the blue ones here, we see that in white women and in Chinese women are slightly less, and South Asian women is slightly less. And so we see this pattern fairly commonly in the populations that we're looking at over here. Now, when it comes to the intracranial hemorrhage or the artery rupture, we see that Chinese women are at no greater risk than white women, and South Asian women are actually at the least. Now, the usual percentages of ischemic strokes to intracranial strokes, if we took all the strokes that were coming into the hospital, is usually 90% to 10%. Okay? That's the usual distribution if we just look at how many strokes are of the ischemic variety, how many are of the intracranial hemorrhage variety. Now, but if we look at men and we look at the same population for ischemic, we see the same distribution, but for intracranial hemorrhage, the highest incidence is in Chinese men, such that if you took national statistics from East Asia, so that means China, Japan, the large, and Taiwan, those countries, you actually see that 50% of their strokes are intracranial hemorrhage. Why is that the case? We just don't know. Is it just uncontrolled blood pressure? We think that may be the cause, but it's not entirely clear yet, and that's still under investigation. Okay, so that's a pretty significant concern. Most of the stroke specialists that are here in San Francisco are very concerned when they have an Asian patient coming in, because they present looking the same, but when you get the CT scan and it shows a major bleed, you really can't do anything. if you see an ischemic area where there's no bleed, but there's an area of damage to the brain, then they can give you the blood thinner, the TPA. Now, why do we go over this in such degree? And why is it that the mortality of heart disease and stroke has really not decreased that much? Because the most common presentation of heart disease and stroke is still the first sudden heart attack or stroke, right? So if the first time you know that someone is sick is when they present with a heart attack, you're already behind the 8 ball in terms of trying to take care of them, because they already have damage in their heart muscle, they have damage in their brain. All you can do is support them until they start to take care of themselves by themselves. So the best way to treat this, and everyone knows this, the wise, honorable physician knows this as well, the best way to treat it is to prevent it, right? And so I would be very unkind to you. I just gave you all this depressing information and said, go out and enjoy yourself. So there is something that we can do about this. And so the one thing that the American Heart Association, the American College of Cardiology did very well was to come up with proven strategies that can help you to reduce the likelihood of having a heart attack, heart failure, a stroke, and even diabetes, and some of the complications that may occur with some of the cancers. And so they came up with this very catchy phrase called the Simple Seven. And as I looked at it, I said, well, yeah, it looks simple, but, and we've given it to many of our patients, and surveys have been done. How often do people actually use this? You know, it seems simple enough, right? Okay, so this is going to be on your slide deck, so if you want to just take a picture of it and put it on your refrigerator, that'd be the best thing to do, and then you could look at it every day. All right, so the idea here is that there are some that we have complete control over. Okay, how we eat, whether we lose weight, whether we move at all, and whether we stop smoking. Well, some people need help, right? I mean, they need smoking cessation programs. Managing blood pressures, you really do need to see a professional at some point in time, either a pharmacist or your physician. Controlling cholesterol, ideally, we try to lower the bad cholesterol, the LDL, and raise the HDL. So far, and they didn't tie this together, does anyone know the best way to raise good cholesterol? You pass the course if you can guess. Okay, so the best way to do this is by exercise. Okay? You know, even eating correctly doesn't make that big a difference. But if you can actually exercise, and I'm going to tell you how much exercise you need to do. You won't be overwhelmed by it, for sure. But it can actually raise that HDL by 15%. Okay, and for HDL cholesterol, that's a good amount. Okay, and then finally, reducing blood sugar. You know, we can eat correctly, we can exercise and everything, but sometimes we need a little medical help. So these things actually require medical help. These don't. Okay, so I would kind of rearrange them so that these are 1, 2, 3 rather than just part of the circle, because this, if we look at it every day, we can take care of that. All right, so let me just kind of go over these because there is research to support every single one of these that they work. Okay, so eating right. So everyone's heard of the DASH diet, which is used for high blood pressure, Mediterranean diet. I don't know how many people like the Mediterranean diet, but it is recommended to prevent heart disease because it does lower cholesterol and it does raise the HDL cholesterol a little bit. And in fact, it has been compared to the more I guess I would say, seasoned Asian diet. So the older Chinese rural diet actually is also appropriate as long as it doesn't have too much, as Don likes to say, MSG and soy sauce to go along with it to make it taste good. But the biggest thing is just to eat in moderation with less than 2,000 calories. Okay, so that you can have a little bit of weight loss. So you don't have to go crazy and say, you know, I have to wipe out all my cholesterol. I mean, I told that to one of my older Chinese women. Basically, because I refuse to give up my rice. And she said, much. And after that, she goes, and joke too, for that matter. And so that's where you get the highest glycemic insult to your system. But white rice, just eat it in moderation. I don't tell anybody that they need to eliminate anything. Now, so the diet portion of it is very simple to follow. And then I wanted to talk a little bit about losing weight. And that's always the most daunting thing to people. Say, how can I lose weight? I'm already 50 years old, 60 years old. I mean, losing weight is like starving yourself to death. And it's not true, okay? The one thing I have to tell you, though, is that with the Asian population, the criteria for obesity is very different than the non-Hispanic white population, okay? So in the United States, all of our criteria for obesity came out of a little place in East United States called Framingham, Massachusetts. And they must have had a fairly good sized population because their average BMI, which means a BMI is the body mass index, is height divided by your weight in kilograms. It was 17 to 25 was normal. 25 to 30 was overweight. Greater than 30 was considered obese, and then there were grades of obesity. I mean, you didn't just stop at obese. They had grade class 2 obesity was greater than 40, and class 3 was greater than 50. And then beyond that, it was just extreme obesity. Okay, so now, in the Asian population, normal weight is 17 to 22. Okay? Overweight is 23 to 25. Obese is greater than 25. Okay? You can imagine my horror when I stepped on the scale and I figured out my BMI that I was obese by this standard. So I said, I'm going to the other standard. So the goal here, losing weight, is not to lose a ton of weight. It's only to lose 5 to 8% of your body weight. Okay? So if you are 200 pounds, okay, then you don't want to lose like 100 pounds to get down to a normal weight BMI. You just want to lose about 10 to 20 pounds, okay? So that is a goal that you set up over a year, not a day, okay? So that you can actually work at it. And so the key here is to be realistic and get an idea of where you want to go. Now, when they said to lose weight and saying that most Americans over 20 years of age are overweight or obese, that is using even the American standards. So that's actually quite large population. And then 32% of children are overweight or obese as well, and they have their own criteria. But for average adults from 25 on up, we should be using Asian Pacific Islanders, if that is your ethnicity category. And why is that the case? Because research studies have shown that diabetes begins more commonly in the Asian population with a BMI of 23. that's also seen in the South Asian population as well as the East Asian population. Okay, so BMI of 23 is what you're shooting for if you want to be normal weight or less. Okay, I don't want to go over too far. The next one is get moving. And this one is the one that I usually spend most of my time with advising my patients, okay? They said, I don't want to go swimming. I don't want to wear running shoes and go out there and make a fool of myself. I said, no, you don't have to do that. I will show you what it is to do moderate exercise, all right? And so in my clinic, I just say, watch. That is moderate exercise, right? So if you can walk and still talk a little bit, all right, that is actually the pace that we consider moderate exercise. Now, according to the American Heart Association, you only need to do 150 minutes a week. So if you break that down into a daily or to a weekly event, that's 30 minutes a day. And get this, you don't have to do it all at once. So you can do 15 minutes here, 15 minutes there, 10 minutes one time, 20 minutes the next time. Mix and match however many times you want to do it, but you want to get about 30 minutes 5 days a week. Okay? And so, and I said, don't run. You know, if you feel like you've been doing this for months and months and it's getting boring at that pace, you might want to just increase it a little bit, but what they call interval training, meaning speeding up a little bit and then slowing back down. But I tell them only once or twice in that 30 minutes, okay? And how long do you speed up? I tell them no more than 15 seconds. So if you're trying to go for a minute or like 30 minutes at a high rate of speed, you're going to kill yourself. You know, and I think that that's one of those unintentional injuries that males have because they're just doing it too much, right? So the one thing is that just get into the habit of thinking of moderate exercise like just a good little bit faster than a casual walk. You know, if you, and what they say is, if you're just starting to sweat a little bit, breathe a little bit harder, or you find that you can't walk with a friend and talk at the same time, then you're going too fast. Okay? So you should be able to hold a conversation. You should be able to walk and maybe have a little bit of perspiration. Okay? So that's the getting moving part. And what we found is that with those instructions, and that's the one thing I check every single time they come in. Now, smoking, obviously, the most recent research has shown that there is no level of smoking that is safe for you. So I have a ton of patients that say, oh yeah, I used to smoke 2-3 packs a day. Now I'm down to half a pack a day. And I think maybe by next year I'll be down to 5 cigarettes a day and possibly even less. And basically the advice that we have to give them is that no cigarette smoking is safe for you, okay? Now, we can't say that entirely about the e-cigarettes or vaping that is currently available, or whether nicotine in other forms is actually safer for you. At this point in time, there's a lot of research going on to see what is the risk of actually using other forms of smoking. Managing blood pressures. So, you know, I know that a lot of my Chinese patients will also say, oh, you know, my blood pressure is 180 over 80, and I don't want to take medications forever. So can you just give me some pills for a few days and I get it down and then I don't have to worry about it? And that's not usually how we manage blood pressure. Okay, so we do a lot of education around that, and it makes it even more, a little more challenging now because so far every edition of the guidelines that we use to diagnose and treat high blood pressure has been going down to lower and lower levels. I don't think it's going any lower than this, but normal blood pressure now is basically 120 over 80. What we shoot for as a goal to treat blood pressure down to, for the majority of people, is less than 130 over 80. Now, that's where some people get very crazy, right? I say, I wake up in the morning, my blood pressure is 170. I take it 5 minutes later, it's down to 140. I wait another 5 minutes and it's down back to normal. Okay, so what happens then? The normal body reaction to sleeping and waking up is that the body knows when you're going to wake up. It's called a circadian clock. So it knows when the sun comes up, and it knows when the sun goes down, and when 2 hours before the sun rises. Okay, usually about 3:30, 4 o'clock. If we did blood pressures throughout the day and throughout the night, we actually see that the blood pressure and heart rate start to rise about 4 o'clock. And that's your body hormone saying, wake up soon. Not immediately at 4 o'clock in the morning. But that's why the blood pressure is highest in the morning. So I said, you might take it if you want to in the morning, but ignore that one. Okay? Don't worry about it, because it's going to be high. All right? Take them a few times during the day. Sometimes take it when you're relaxing, ready to go sleep. And don't just sit down, slap it on, and say, I'm not feeling well. And then your blood pressure will be up, I can tell you that. Okay? But if you sit there and I just tell them, wait 7, 8 minutes and then repeat it again. If it's coming down and you repeat it again, it'll be even lower still. So don't worry about that. And so what do we consider good control of your blood pressure? 50% of your blood pressures are within that target range. Not 100%. If we treated you so that none of your blood pressures were over 120 over 80, everyone would be walking around like this. No energy, dizzy, thinking that they're about to pass out. Okay? So there's such a thing as too much blood pressure control. The best blood pressure control has a little bit of fluctuation in it, and that 50% of the blood pressure is within target. Okay, so controlling cholesterol, we tend to use medications for this. Many people like to use diet. I tell you that exercising can actually lower the bad cholesterol about 15% and raise the good cholesterol about 15%. And that's with that 150 minutes of moderate exercise. That's what it was tested for. Okay, so that has been shown to be effective. So if you say, I don't want to take medicines, let's try this first. Okay, it should have an effect within 3 months. And that's the recommendation by the Heart Association. Okay? And then finally, reducing blood sugar. Why is that the case? Because people who have elevated sugars and diabetes tend to have heart disease problems, and they die from heart disease rather than diabetes complications. Okay, so we really focus on that, although the information about actually treating each of the high glucose down to normal has not been that convincing. But one of the things that the Food and Drug Administration, the national organization that tests for every drug for safety, they said all diabetes drugs now have to be tested for their effects on the heart. And so we've actually discovered 2 new heart medicines that were originally developed for diabetes, and they work in patients even without diabetes that help the heart. Okay, so that was a very key finding based upon the research that diabetes affects the heart just as much as if you had a heart attack. All right, so for those people who don't like to see so many words and like to see pictures, I got this for you. All right, so this is the same. Now, as I said, one of the things that was concerning is that this has actually been out for the last 10 years, okay? And we did a survey every other year. How many people are actually doing this? How many people are doing all 7 of these? And the question to how many people were doing all 7 of these, does anyone know the answer? It was like 2%. It was in single digits. Okay? Now, not all hope is lost. So we look at the young population, okay? And this is 12 to 19. We actually see that of the non-Hispanic Asians, they actually won the prize, all right? They had 65, close to 64% of the Asians actually had greater than 5 criteria, okay? They were the best. And then the lowest was the non-Hispanic blacks at 35. But then once they became adults, I take it like all of you and I. So you see that they were still ahead, but it's less than 30%. Okay? So getting all 7 was like out of the question. So this is what we need to work on, because we know that every single one of those things work. And if you put them all together, you can actually reduce heart disease and stroke. Okay? So that's all I have prepared. Thank you very much. If you have any questions, I'd be happy to answer them. If you have any questions, I put it in the back. I try not to use a smaller font, but this is the same font with all the other slides. Yes?
Can you comment on a study that was done a few months ago that stated, it was a meta-analysis that stated taking blood pressure medication at night reduced the spike in the morning when we arise lower in the chest of getting a CVD heart attack.
So the question was whether this one study that mentioned that taking your blood pressure medicines at night was actually helpful in terms of reducing that morning spike. So one of the tools that we've developed for monitoring blood pressure is called a 24-hour blood pressure monitor. And what it does is it takes your blood pressure during the day every 20 minutes, okay, while you're awake. And then you report to the technician what time you usually go to bed, and then it'll switch the frequency of blood pressures to once an hour in the evening when you're supposed to be sleeping, so you won't be waking up so much. And what they found is that there are some people that have a dramatic rise in their morning hormonal surge to wake up. And so that blood pressure could sometimes be quite harmful if it's sustained. What they also found is that if you give blood pressure medicines at night, that it can actually temporize that. It will actually make that so that it doesn't go as high. What was also another benefit that was found in that is that the studies that looked at that, and what you mentioned was just the last in a series of trials, said that if you take the medicine at night, you see that the blood pressure does drop like it's supposed to, but it drops while you're in sleep and in bed. So the likelihood of getting lightheaded from a low blood pressure reading is markedly decreased because you're not moving around, you're not standing up, you're not sitting up, right? And so people who take their blood pressure medications in the morning, usually they complain to me about 2 hours later that they're feeling a little lightheaded, they're feeling a little weak, and so then I just tell them, take it at night before you go to bed. Not just at night. So what is the most common understanding? Nighttime begins at dinner, right? So I just take it at dinner. Well, we don't want you to do that. What time do you go to bed? If you say you ate dinner and you go to bed, then that's fine, okay? I say take it when you're ready to get into bed. Then the 2 hours starts from there, and if you get a low blood pressure drop from the medicine, it'll be while you're sleeping, hopefully not getting up to go to the bathroom. Okay? Other questions? Yes?
What about statins?
What about statins? Okay, so I know for the Asian population there's been a big concern. So one complaint that I used to get commonly was, I don't want to be on a medication for the rest of my life. I said, if I start this, I'll never be able to stop it. And I told them that the literature does not support that, okay? The literature supports that if you can get, while you're taking the statin to get it down immediately, if you can exercise and you can bring it down to that level that you want it, and we say that the American Heart Association has established standards. If you have heart problems or you don't have heart problems, what we should get the level down to. And you could do that without medications, then I will lower the dose or even eliminate it. Now, the other concern that Asians have a lot is that they're concerned that statins actually affect the liver. And there's a lot of hepatitis and other liver diseases in the Asian population. In fact, the effect on liver is actually quite low. But the recommendation is once you start one of these medications is to check a liver function test in 3 months. And if there's no problem, then it's very unlikely that you're going to develop hepatitis from or destruction of your liver from the medications. Now, on a rare occasion, very rare, it can cause muscle inflammation, and that would be an indication to stop it. But a lot of people who start it and say, oh, I have muscle aches, and it's usually in my back and my legs. This is not uncommon with that, but what we found is that if you just exercise or rest it, it will go away. What we've tried even was stopping the medication, it went away, put them back on it, and didn't come back. So, it's just something that comes and goes. But the biggest concern is the one where it actually inflames the muscle, because then that one we have to change, and then any very rare effects on the liver. Okay, yeah.
Doctor, for your patients who are on statins, how do you feel about them taking a supplement CoQ10? And how does the statin affect the level of that particular enzyme? And do you recommend oil or some other?
Excellent. Okay, so the question is, if patients are on a statin, what are my feelings of them going on CoQ10? And I must say I'm very flexible about that. But there's not a whole lot of guidelines to say that there's an interaction that you have to avoid. There have been studies that show that if you have muscle aches, the CoQ10 might be very helpful in relieving some of those. Some people who take the statins might get a mild GI upset, nausea. The CoQ10 will also be effective in doing that. I have not heard or read of any interactions with CoQ10 that would obscure its use. Okay, and I have many patients who say, well, you're only my second doctor. My first doctor is my grandmother. But yeah, and so they'll say, I need to take, whatever soup or tea she's making. And I said, that's fine, but let's check you afterwards, and if it didn't do the thing, we'll have to start you on a statin. Then we'll have to do at least what I know works. Okay, so we do have all those situations where, now, we have to be very careful because there is an organization that looks at all herbal medications and supplements. And so some of them actually have allowed themselves to be tested and put on their packaging that they have been tested for safety and things like that. The only one dramatic case that I had of someone taking herbs and we didn't know about it was a young woman with her baby, and they were having cold symptoms, and they went to, they didn't go to even an herbalist. They just went to a nearby store and they picked up some things. And when they came into the hospital, they were very sick. And we tested it for all the American medications that we knew because we didn't know any of the Chinese ones, and found that they actually had a very potent heart medication levels that were toxic. And so the baby and the mother were very sick for a while. Yeah. So I'm very careful about too many herbs in that. And so just to check it out and mention it to your doctors. That Western trained doctors are not very, but we have an alternative medicine group here at UCF that does look at a lot of the herbal supplements that people are on as well. Okay, any other questions? Great, thank you very much. Oh yeah, no, what's up?
Fish oil?
Fish oil, okay. Yeah, so fish oil, so the question is fish oil. So it's actually had a very good reputation for doing one specific thing, and that is lowering triglycerides. That's another body fat. Triglycerides are one of the body fats that have had a kind of waxing and waning history, because for the longest time we just could not prove that lowering the triglycerides by itself did anything to prevent heart problems. And that was the gold standard. It had to show that there was less heart problems if you took that medication. So standard fish oil is pretty much, that's what we worry about, is that you'll run into that. There's recently been a major trial going through the FDA, which is basically a purified fish oil product called SEPA, and it lowers triglycerides as well. Okay, and it has been shown to reduce heart disease. So if you like that, some patients that I take care of that take a lot of fish oils, they wake up in the middle of the night smelling like fish. So that's why they don't take it. Not because they don't think it works. They just don't want to smell like fish and sleeping with somebody. Okay, yeah.
Also, when I use the treadmill to get into shape, there would be charts based on age and weight to determine your target pulse, so you're exercising correctly. I was also taking high blood pressure meds. I could never seem to reach the target pulse, no matter how hard I exercise. So, is there a compensation factor I should have?
Okay, so the question is, if you use the exercise treadmill and it has all these guidelines based upon age and gender, actually should be as well, then and you have trouble getting up to that, what we call age predicted maximum heart rate. So the usual average formula is you take 220, okay, and you subtract your age, and that is the target for a person to achieve on average for 100%. Now, when you're just doing it for exercise, we say shoot for 70% of that. Okay, don't try to go to 90%, just try to go up to 70%. The average person should be able to do that. If you can't, then we have to look at other reasons why you can't. Now, sometimes if you're taking medicines for high blood pressure, some of those medicines can actually slow your heart rate down. And so you can't break through it. You know, you're going to be limited in terms of how high your heart rate can go. So the compensation is you go into your, like I described earlier, just feeling a little short of breath, if you like talking to your pet or something and you can't talk anymore, then you know you're going too fast. Okay? Other things. Yeah.
I have some friends that are acupuncturists.
Uh-huh.
And they mentioned that, that acupuncture does help if you have a stroke, but the first 2 weeks after a stroke.
Helps cholesterol?
No, well, a stroke.
Okay.
Get a stroke. And then if they do have a stroke, if they get acupuncture within the first 2 weeks, it helps to minimize the stroke.
Okay.
Do you know anything about that?
So the question is the use of acupuncture after stroke, and there are some acupuncturists that will actually advocate for intervening as early as possible so that they can help in terms of the management of the stroke. Now, for the majority of patients with a stroke, ultimately we will, for ischemic strokes, we will actually be doing the same thing. We'll be doing what's called secondary prevention, controlling blood pressure, managing your cholesterol, getting you to exercise, and if you have elevated sugars, controlling those. So those are the major things that we put you on medications to keep the arteries from clotting up. And so there have been studies looking at acupuncture. Sometimes it's relaxing enough that the blood pressure doesn't continue to rise, and so we may not need medications for that as much. We don't want to lower elevated blood pressure in a stroke too rapidly, otherwise the brain can feel like it's being robbed of blood pressure, and so then it'll have other kinds of reactions. The other thing is that I've not seen anything where acupuncture can actually affect any of the cholesterol levels or sugar levels or anything like that. But there is an excellent thing that it does do in terms of relaxation and preventing nausea. There are acupressure points as well to help with nausea. So I don't know what the there's actually an acupuncture association and a certification board, whether that is considered an indication for acupuncture. Do you know, Don?
I think, I've had patients tell me, and other acupuncturists tell me that you can speed up recovery from a stroke in terms of motor function, speech function, whatever, with acupuncture. The problem is that a lot of this is anecdotal, and we don't have good data to research studies that come out that say, hey, this really works. And there are some studies of sham acupuncture for other types of diseases which show that for certain illnesses they do work, but those studies need to be done. There's a group being led by my colleague, Dr. Fung, who's trying to work with the American College of Traditional Chinese Medicine and the CIS, which is the California Institute for Integrated Studies, trying to converge Eastern and Western medicine. And one of the acupuncturists at the Osher Center trained with ACTM, TCM, and he actually does acupuncture for certain limited situations in the hospital. We're trying to expand that, but unfortunately, UCSF has a huge bureaucracy, and trying to get that through is really hard. I know there is acupuncture going on at Highland General Hospital, actually, and I think there's more acupuncturists performing acupuncture at the San Francisco General Hospital, but they have to yet overcome the hurdles at UCSF. But we hope that will happen one day, and then we can actually show and prove how acupuncture or even Chinese herbal medicine can help with certain diseases.
Great, gave me my next research project. Okay. All right. Well, any more questions? All right, thank you very much for your attention.